metabolic dysfunction associated steatotic liver disease. This topic is purely on the alcohol related liver diseases. The risk of developing the cirrhosis increases with the ingestion of the alcohol. Alcohol is also called as the ethanol. So as a professionals, we always say that ethanolic, not an alcoholic, okay? Ethanolic ingestion or ethanolic toxicity. So the men more than the 60 to 80 grams per day of the alcohol for more than the 10 years, so they're likely to get the cirrhosis of the liver. Not all, some population. In the women more than the 20 to 30 or the 40 grams a day for more than the 10 years is sufficient to cause the cirrhosis in a susceptible individuals. So here you have the 1, 2 and 3. So the normal liver that goes either the steatosis or directly to the hepatitis. The steatosis means a simple fatty infiltration. So the normal is less than the 5%. When the more than the 5% of the hepatocytes is filled with the fat, we consider it as the steatosis or the fatty liver. So here the fatty change and the perivenular fibrosis. And some people, after abstinence of the alcohol, so again they go back to the normal liver. So the normal liver on ethanolic intoxication or exposure to the ethanol for a prolonged years, about 60 to 80 grams or more than the 20 grams on males and the females, so likely to have the steatosis. And if they stop taking the ethanol, so again they come back to the normal liver. So that is an exchangeable or the reversible process. And some people with the normal liver on the binge alcoholic ingestion, so directly they may go into the hepatitis phase. That is the phase 2, where itis means inflammation. So not only the fatty infiltration, there will be the inflammation in the hepatocytes is also will be there. So that is the liver cell necrosis will start, inflammation, Mallory bodies and the fatty change. So that is the stage 2. See, stage 1, that is the steatosis, can go into the stage 2 also on the severe exposure or the continuous exposure. Now the 2 will enter into the stage of the 3, or unfortunately some people with just fatty liver without the inflammation, without the second stage, they also go into the stage of the cirrhosis. See, this is the cirrhosis, the fibrosis, hyperplastic nodules. You can see the hardness of the liver here, and there are all the fibrosis, nodules, etc. So that is a cirrhosis of the liver. So we are all happy if it starts at the stage of the steatosis and stay there only. But unfortunately, some people go into the hepatitis, and some people they directly go into the cirrhosis. So this cirrhosis is also a chronic problem and a troublesome disease with a lot of the comorbidities and the mortality like varicose bleeds, subacute bacterial peritonitis, ascites, etc. This is a worldwide problem. So a national problem, a state problem, resulting in several deaths. See, alcohol consumption, world's third largest risk factor for the disease and the disability. Almost 4% of all deaths worldwide are attributed to the alcohol. I think there's a old one. Now maybe the 5.5 to 6% of all deaths all over the world are attributed to the alcohol. It's a very, very high in number. Also, there are many serious social issues like include the violence, child neglect, child abuse, absenteeism from the workplace. So these are all very common. You all know the ill effects of the alcohol from your alcoholic encephalopathy or alcoholic cardiomyopathies, alcoholic hepatitis, alcoholic gastritis, alcoholic pancreatitis. So these are all we often see in the casualties every day, at least 1 or the 2 cases caused by the alcohol and its ill effects. Globally, nearly 6 or 7% of all male deaths are attributed to the alcohol compared to 1.1% in the female deaths. So they are very high. Men also have the far greater rates of the total burden attributed to the alcohol than the women. So this is the 6.2 liters of the pure alcohol consumed by every person aged 15 years or the older. That is 2005. Maybe this time, maybe 12 liters, maybe 18 liters, 20 liters. It's up to your guess. Highest consumption found in the developed world, Northern Hemisphere, Argentina, Australia, New Zealand, and you can also include Andhra. Alcohol consumption worldwide. Total adult per capita consumption in liters of the pure alcohol. Effect on the health, directly proportional to the volume of the alcohol you ingest, quality of the alcohol, and the patterns. So they cause both the chronic infectious conditions as well as acute conditions. So they cause lot of health outcomes, and finally the mortality depends on either alcohol directly induced, like your pancreatitis or hepatitis or encephalopathy, or sometimes maybe because of the violence or the accidents, etc. So this is the mechanism of the liver damage. So alcohol intake leads to the formation of the toxic metabolites. Here the ethanol or acetaldehyde that generates acetaldehyde, which is subsequently oxidized to the acetate by ALDH. Acetaldehyde can form the hybrid adducts with the reactive residues acting on the proteins or the small molecules, leading to oxidative damage. So this oxidative damage is very, very important. Not only the oxidative damage, there will be the lipid peroxidation, adduct formation, and mitochondrial death, and CYP440 alterations, and NADPH oxidase mechanisms, phagocyte activities. So these all will be disturbed by ethanol or acetaldehyde, and finally lead to the alcoholic liver disease, a simple steatohepatitis or cirrhosis or hepatocellular carcinoma at a later stage also. So these are the major lesions. Alcoholic fatty liver, more than 90% of the binge and the chronic drinkers will get this fatty liver, alcoholic fatty liver. So nowadays most of our people, they get the fatty liver even without the alcohol also. So that is your obesity related fatty liver or your metabolic dysfunction related. Alcoholic hepatitis, the precursor of the cirrhosis. Once they get the alcoholic hepatitis, so definitely it's very difficult to stop them, alcohol in them, because alcohol runs in the families and alcohol dependence is also very high. So even though you say anything, so those most of the people, 99% of the people, they don't stop taking alcohol in spite of an attack of pancreatitis, in spite of an attack of 2 or 3 attacks of gastritis, or in spite of their heart failure caused by the alcoholic dilated cardiomyopathies. Still lot of the people, they keep on continuing the alcoholism. So alcoholic cirrhosis is the end result of the chronic heavy drinking. Incidence of the alcoholic hepatitis, so develops in only 10 to 20% of the chronic drinkers. Why not in other people? Because of their good metabolism in the liver. They are lucky people. They don't get even, they take heavy alcohol ingestion, but 10 to 20% is a very high number. Because if you see the society, so out of 100 people in the society, I think 60 to 70% are taking the alcohol. Some people have a daily basis, or some people maybe the weekly basis, etc. Risk factors include the female gender, heredity, and the immunity. These are the, why do only 20% of the develop the alcoholic liver disease? Why not the others? Because of genetic variability, alcohol metabolizing enzyme. Genetic variability in response to the damage of the hepatocytes, pro-inflammatory genes, so predisposition to the autoimmunity, obesity, and gender. Cofactors like iron, drugs, toxins, alpha-1 antitrypsin deficiencies, etc. and infections with the hepatotropic viruses like Hep B, Hep C, Epstein-Barr viruses and other viruses which attacks the hepatocytes. They also damage the liver much more in a people who are on continuous alcohol ingestion. So these are all the variables, host variables. So you all know that ethanol will make the normal liver into the steatosis stage, and in the steatosis stage they lead to the hepatitis because of these pro-inflammatory markers, and this alcoholic hepatitis will end into the cirrhosis because of the pro-fibrotic mechanisms. So these are the pathways. So normal liver will become the steatosis because of the ingestion of the alcohol, and after the steatosis origin, so there will be the pro-inflammatory markers, and then the fibrotic markers will lead to the cirrhosis in about 10 to 20% of the alcoholics. So the most important thing is the quantity of the alcohol and the duration of the alcohol intake rather than the type of the alcohol. Some people, they said, I take only very costly drink so that I don't get the cirrhosis, etc. So that is not true. So it is the quantity of the alcohol that matters a lot. And the pattern of the drinking alcohol, a direct hepatotoxin, involves the release of the pro-inflammatory cytokines and tumor necrosis factor alpha. So the contributing factors, unfortunately, Indian population, we have a lot of Hep C and Hep B associated in the society, very high, especially in the Konaseema areas. Hep C is very, very common in those areas, especially the Amlapuram, and hepatitis B is also very common all over India. And non-alcoholic steatohepatitis, NASH with or without the obesity. Alcoholic fatty liver, macrovesicular steatosis starts with the perivenular hepatocytes. Accumulation of the fat due to the inability of the hepatocyte to process and transport the fat, and benign and the reversible, that is the fatty liver one. Once it goes into the hepatitis, characterized by ballooning of these cells, and there will be the degeneration, there is the necrosis, there will be the polymorphs infiltration, and fibrosis start appearing. So that is your hepatitis stage, where there will be the ballooning, degeneration, necrosis of the hepatocytes, and polymorphs infiltration with fibrosis. Mallory bodies may be seen, but is not the specific, not in all the individuals, but once they see the Mallory bodies, then more specific of it alcoholic hepatitis, and reversible unless with the cirrhosis. So the same thing here, the alcohol increase intestinal permeability in some individuals, so they cause endotoxins. Endotoxins will liberate the Kupffer cells, and finally they lead the collagen and the fibrosis. And sometimes they damage the hepatocytes, will lead to the necrosis of the hepatocytes and inflammation or apoptosis or oxidative stress. So that also will lead to the necrosis and inflammation, and direct acetaldehyde directly may cause the immunological damage and lead to the necrosis and inflammation. So the clinical features, most of the times they are asymptomatic. So that is the beauty of our physician practice. The person sitting before you, most of the time they are asymptomatic, whether they are type 2 diabetes or hypertensive or alcoholic liver disease or CKD or osteoporosis or COPD. So these are the lot of the diseases we see day in and day out in our practice, but most of them they are asymptomatic. So except for the hepatomegaly, so that means you have to elicit it. You have to elicit the history of the alcoholism, you have to see whether the hepatomegaly is there or not, and any past history of alcoholic related diseases like past history of admissions for gastritis, past history of the admission for pancreatitis, etc. Hepatitis may present with the fever and abdominal pain, but may also be asymptomatic. May also present with the hepatic parenchymal dysfunction like spider angiomas, jaundice, or portal hypertension, that is ascites, varicose bleed, in the absence of the cirrhosis. See, once the patient is in the cirrhosis, obviously it's a spotter for you. So the abdominal distension, ascites, then the hypocritic facies, parotid enlargement, palmar erythema, we can obviously see, and it is almost like a spotter when the patient enters into a stage of the cirrhosis. But the beauty of the physician is you have to identify at the level of the fatty liver or at the level of the steatohepatitis, so that a reversible mechanism may be seen. So once he gets abstinence from the alcohol, and obviously his liver will become the normal in a span of maybe 6 months or 1 year or 2 years. But he doesn't stop, so definitely go into the stage of the cirrhosis where there is no reverse back. Lab investigations, see LFT, your AST and ALT, SGPT and SGOT will be elevated, and here AST by ALT ratio, so SGOT by SGPT ratio usually more than the 2 in alcoholic hepatitis or alcoholic liver disease. And the GGTP is also will be elevated, but not the specific. Mostly it will be elevated in the alcoholic liver diseases, but sometimes even in the non-alcoholic liver disease also you can see the elevation of your GGT. Ultrasound, yes, it dates the hepatic enlargement, maybe the fatty liver grade 1 or grade 2 or the grade 3. Sometimes the people, some have in alcoholics, if they consume lot of the kallu, so then they develop the liver abscesses, hepatic abscesses. So that also can be seen on the ultrasound examination, and you can drain this hepatic abscess under ultrasound guided aspiration of your amoebic liver abscesses or multiple liver abscesses also can be seen. Hepatic synthetic functional derangements like decreased albumin, this is also very common. These people, they don't eat, they keep on drinking, so obviously they will develop in the hypoproteinemia, so the edematous conditions, anemic, etc. So you have to get the serum proteins that will be less than 6, and your albumin will be less than the 3, maybe 1.5 or the 2, etc. And globulin may be elevated, there will be altered albumin globulin ratio. Clinical subsets of the alcoholic hepatitis. Asymptomatic. Majority of the cases, you will have the hepatomegaly, you will have the biochemistry mildly abnormal. So maybe your bilirubin may be 1.8 or 1.8, your SGPT may be 60 or 80, your SGOT may be 80 or 40, and GGT will be elevated, alkaline phosphate will be the normal, the proteins may be the normal, maybe at the level of 6, or sometimes maybe 5.9 or 5.8, etc. your albumin may be 3.4 or 3.3. So a mildly elevated, deranged lab values will be seen in these individuals. Even though some people know they don't give the history of the alcoholism, but even though they are alcoholics, then we can pick up with these investigations. Needs histology for the confirmation. Still you are in the doubt. We don't know whether these elevated biochemical values are definitely due to the alcohol or not. We don't know, but usually we can assess them. The liver failure. In the liver failure, so definitely the bilirubin greatly increases. Sometimes the serum bilirubin may be 15, 20, 35, 40. So last week I have seen one fellow with the bilirubin of 33.6. Very high, elevated bilirubins. Alkaline phosphatase is modestly elevated. PT is also increased. Albumin is reduced, and neutrophilia will be there. Thrombocytopenia will be there. Sometimes they develop the pancytopenia also. And ascites is obvious. So these are all the features of the liver failure. See, at this juncture, very little can be done. So as a good physician, you have to identify the people at the stage of the fatty liver or steatohepatitis. Don't go into the stage of the cirrhosis. And at the level of the cirrhosis, very little can be done. And we have to submit we have to refer these cases to the hepatologist or the gastroenterologist for further management of varicose bleed or bandings, etc. Last week I have shown you one case of hematemesis or gastric banding was done in that case. So that time we should not invite such type of the complications in our population. The clinical, biochemical and imaging and alcoholic liver diseases. So spectrum is alcoholic fatty liver at this stage, in the stage 1. Clinical features mostly the asymptomatic, or sometimes they may have the right upper quadrant pain, maybe because of your stretching of your hepatic capsule, that is hepatomegaly, in the early stages. Imaging ultrasound, yes, abdomen shows in a hepatomegaly. Some people may be the normal liver also. CT abdomen, for assessment of the liver fat, we get it the fibroscan rather than the CT abdomen. We see the fibroscan to know the fatty liver and your KPA levels. So KPA level should be the normal less than the 6. If it is more than the 7, it is an abnormal. Depends on the stage 1, stage 2, stage 3, more than the 13, very, very abnormal. MRI abdomen, that also your MRI angiogram is also can be seen, and transient elastography with the cap is emerging in the imaging. That is the most important one. It is the fibroscan, nothing but. Laboratory findings, normal liver function test when the fellow is in the alcoholic fatty liver or slightly elevated enzymes, and imaging shows the fatty liver. So we are happy with these investigations at this juncture, and you can guarantee him a normal lifespan if he abstains from the alcoholism. If not, he will enter into the second stage, that is the hepatitis, alcoholic hepatitis. Here a combination of these symptoms and the signs. He may develop the jaundice, loss of appetite, right upper quadrant pain or the discomfort, maybe mild ascites, asthenia, confusion, pedal edema because of the anemia, petechial spots, and sometimes the fever, hepatomegaly, which may be the tender hepatomegaly. So these are the signs and the symptoms you can elicit at a stage of the alcoholic hepatitis. Imaging, more of the clinical diagnosis, ultrasound abdomen or CT or MRI, it all shows the features of the alcoholic fatty liver and or cirrhosis with or without the ascites. And laboratory findings, the bilirubin keeps going, more than 3, more than 5, 10, etc. And there will be your SGOT, SGPT is also will be elevated, very high, maybe 3 to 5 times more than the upper normal limits. And also your GGT is also will be elevated, your albumin will be reduced, your proteins will be reduced, your PT will be elevated in some cases, not in all. It is at the stage of the alcoholic hepatitis. Again, it is a reversible one, easily treatable by a good physician. But the problem is here. Cirrhosis without the alcoholic hepatitis. Here may be totally asymptomatic in compensated cirrhosis or anorexia, weight loss, fatigue, muscle cramps, ascites, impotence, infertility, impotence because of the sex hormone degradations, infertility, again the same, loss of the pubic hairs, palmar erythema, pedal edema. So these are all the classical features of your chronic liver disease. Jaundice and ascites may be present in the decompensated disease, firm liver which may feel nodular and then the liver is going into the stage of very hard liver, that is your cirrhotic liver. Whereas in the early stages, the liver is tender, liver is enlarged, there will be palpable. In the imaging, ultrasound abdomen course and echo pattern and nodularity of the liver. So the normal liver is very sharp inside, but whereas in the cirrhotic liver, definitely there is a big nodularities will be there, the nodules will be there. And again the CT and abdomen is also same, the transilluminography to elicit the liver stiffness. And then the low platelet count, here again the platelet count will be reducing. So that lower the platelet count, definitely the poorer the prognosis, and elevated the bilirubin levels. Here the cirrhosis and also the hepatitis, the same thing here, the laboratory features are very, very high. Here high INR with the low hemoglobin, albumin and the platelet count. So you need fresh frozen plasma, you need packet cells infusion, you need platelets infusion, etc. And you need albumin, you need blood. So these are very, very common in decompensated cirrhosis. So the prognosis of the alcoholic hepatitis, why score it? To identify the patients at the greatest risk of the death. So the ones that they are in the stage of the cirrhosis or in the stages of these things, so definitely the mortality will be very high. So to decide which patient we are going to lose it. So decide when to offer the second line of the treatment, like steroids or the pentoxifylline. So don't use them in the initial days. So only when they need it, then you can use the steroids or the pentoxifylline. The design of the clinical studies for the treatment of the alcoholic hepatitis. These are the different scores. So the DF, discriminant function, MELD, model for the end-stage liver disease, and ABIC, depending on the age, bilirubin, INR and the creatinine. So these are the different calculators are there, interpretation and most of the remarks. The scores for assessing the severity. So GAH score, Glasgow alcoholic hepatitis scores, etc. So 1, 2, 3 depending on the age, and your leukocytes count, urea, so the hepatorenal syndrome, INR and bilirubin. So depending on these levels, we can calculate, we can decide them as the 1 or the 2 or the 3. So the more the risk or the higher the diseases. So interpretation, poor prognosis if the score is more than the 8. And most of them they need the hospitalization, etc. Requires more variables than the other scores also. So once the fellow's age is increased, leukocytes are very much reduced or very much high, and urea is increasing, INR is increasing, bilirubin is increasing. So obviously the score will be very, very high, and there is a patients with who requires an intensive management. So this is your popular score, child pox score. Here you can see the score depending on your bilirubin levels, albumin levels, PT levels, ascites and encephalopathic grade. So here 1, 2, 3, 4, 5 points, etc. So depending on these points, again you can say that this patient can be treated by yourself, or we have to refer them to an institute where a multi-specialty care is required. So this is the very important. So in all the hepatitis individuals, or in the fatty liver or the cirrhosis, etc., we have to see these things. Don't be happy with only bilirubin and LFT only. LFT includes the proteins. So proteins includes the albumin. Again the PT-INR, these are very, very important investigations in sick patients. So general management, stop drinking, very easy to say but very, very difficult. Nutritional support, manage the withdrawal. So some people they develop withdrawal symptoms. Manage the complications of the portal hypertension and ascites, encephalopathy, varicose bleed, etc. They treat extrahepatic complications. Because some people may have the hepatorenal syndrome, some people will have the tachyarrhythmia, some people will have the encephalopathies, some people will have the thrombocytopenia, some people will have the bleeding tendencies. So these are all you have to treat them. So disease-specific steatohepatitis, cirrhosis and decompensated cirrhosis. Achieving the abstinence. The backbone of the treatment of these patients with alcoholic liver disease is the achievement and the maintenance of the alcohol abstinence. The efficacy of the medical treatments is limited in those who continue to drink. But unfortunately, 95% of my patients, they continue to drink in spite of these different attacks every year. They don't bother about the lifespan. Pharmacotherapy of the alcohol use disorder. So these are all FDA approved drugs. Acamprose, out of them we use the disulfiram. So the disulfiram is freely available in the market. So under the guidance of the good psychiatrist, we give them the disulfiram. Maybe the initial dose of 250 milligrams or the 500 milligrams, OD or BD or the TID, etc. So this is acetaldehyde dehydrogenase inhibitor. This acetaldehyde is the main reason for your different pathological steps in the liver at the hepatocytes. So use 250 milligrams to 500 milligrams orally daily. No hepatic metabolism, also the drug induces liver injury. These are the other drugs. So baclofen, usually we don't use them here, but some people they develop the hiccups in alcoholic hepatitis and etc. There we can use the baclofen. Gabapentin as a drug GABA modulator. Topiramate, it is an anticonvulsant and very clean nicotine receptor agonist. Nutritional support is very, very important. Most of these people are deficient in the vitamins, they are deficient in the macronutrients, micronutrients, etc. So their patients with alcoholic liver disease often present the severe primary and secondary malnutrition, particularly protein energy malnutrition. So you give them the good protein, not 1 gram per kg body weight, maybe 1.2 or 1.5 grams per kg body weight. A dietary intake of 1.2 to 1.5 grams of the protein per kg and 30 to 35 kilocalories per kg body weight. Frequent meals, including a nighttime snack, is almost recommended. But most other people, they don't believe in here. So instead of spending money on the protein, again they keep on drinking. Considering the numerous micronutrient deficiencies in the advanced ALD, adequate supplementation thereof is also very much needed. Infections are very common. So these individuals, the most troublesome in Indian population is the infections. Infections. So we are very fortunate to study medicine in India. On one hand, we see a lot of the infectious diseases. On the other hand, we also see the non-communicable diseases like diabetes, hypertension, etc. So infections are very, very common. You name any infection, that is number one in India. They are common complications of the alcoholic hepatitis and contribute to increased mortality in alcoholic hepatitis. Whether it is Pseudomonas or the Proteus or the Shigella or Salmonella or E. coli, Staphylococcus, Streptococcus, Pneumococcus, Meningococcus, including your hepatitis or HIV, these are very common in the alcoholic individuals. Up to 26% of the patients with alcoholic hepatitis initially present with the infection. Baseline screening for the infection, your blood cultures. Not only your blood culture and the urine culture, maybe your ascitic culture, maybe your pleural fluid culture. These are also very much needed. X-rays, not only the chest X-ray, maybe CT chest and ascitic fluid analysis for your ADA is routinely performed. A clinical trial studying the use of the amoxicillin clavulanic acid with the prednisolone in patients with severe AH was nearly completion. So these are the treatments of the alcoholic hepatitis. Steroids may be used in some individuals, not in all. Pentoxifilin in some individuals, N-acetylcysteine, and enteral nutrition, parenteral nutrition. Those people who keep on continuing with the vomitings, abdominal pains, etc. So steroids for alcoholic hepatitis are practical. Consider the steroids. Biopsy shows the marked inflammation. So that shows your autoimmune destruction in the cells, your Mallory cells, Kupffer cells, etc., or necrosis of the hepatocytes. So your biopsy shows very high inflammatory markers. So definitely there is a role of the steroids in them. But be careful that absence of the overt sepsis or the bleeding. Once the fellow is in the sepsis and keep on using the steroids at higher dosages, again, so there will be the multi-organ failure and the sepsis, severe sepsis. And in the same way, when the patient is bleeding, and if you keep on using the steroids, so definitely you will go into very, very high hemorrhagic events. So they treat with the prednisolone 30 milligrams per day for about not 5 days or 6 days, maybe 1 to 2 months or 3 months also. So sometimes not only the 30 milligrams, you go up to the 60 milligrams also, maybe 1 mg per kg body weight. And some on the maintenance, you can use with only 5 milligrams the prednisolone or 2.5 milligrams of prednisolone also in a tapering dose. What are the benefits? It is an anti-inflammatory steroids. They reduce the cytokines, so the pro-inflammatory cytokines. They prevent the tissue injury, anabolic effects, so they gain weight, and their short-term gains will be there with the steroid, not the long-term gains. Long-terms always dangerous. So that induces long-term treatment of steroids cause diabetes, they cause hypertension, they cause obesity, they cause Cushingoid, they cause osteoporosis, they cause gastritis. So these are all very, very high amounts of the side effects will be seen on the long-term basis. But unfortunately, most of our village people, for osteoarthritis, etc., they keep on taking the Vicelone 5 mg, 10 mg years together. So finally, they enter into a stage of osteoporosis and falls and fractures. So the problems, the systemic sepsis, tissue viability, diabetogenic and hypertensionogenic, inhibit the liver regeneration and no long-term survival benefits. Now, world is for the liver transplants. Now, every multi-specialty hospital, you have the liver transplant surgeons. In Hyderabad itself, there may be more than 50 liver transplant surgeons are there. In Visakhapatnam, maybe more than the 5 people. Even in Kakinada, 1 or 2 people are there. So the liver transplantation is a very common nowadays. Who fail corticosteroids, poor long-term survival, report up to 75% 6 months mortality. Therefore, liver transplantation has emerged as a potential curative therapy for the alcoholic hepatitis. Multi-center European trial, early liver transplantation for steroid non-responders afforded a marked survival benefit when compared with the historical matched controls. 6 month survival of 77% versus 23% respectively. We are seeing a lot of the people who have undergone the liver transplantation, they are doing extremely well nowadays. So, in summarizing, alcoholic liver disease is one of the important causes of the death due to alcohol in an adult, not only in the adults, in the adolescents, and maybe not only in the adolescents, even in the children also. They start taking the alcohol at the 8th class, 9th class, 10th class also nowadays, very unfortunately. Treatment of alcoholic hepatitis and accompanying remain largely unchanged. A marked increase in the number of the diagnostic and therapeutic trials in the last decade, however, reflects a growing interest in this disease. Liver transplant is a life-saving therapeutic option for alcoholic hepatitis and is to be encouraged particularly in patients with a favorable profile. Thank you.